to you.
Hello, Vikas sir.
Hello.
Hello, Mr. Vikas. Sir, you can start.
So, on behalf of Core Diagnostics, I would like to welcome all the faculty members uh, and all the doctors who spared their precious time, their valuable time from their busy schedule. I especially thank Dr. Madan Piya, Dr. D.C. Doval, Dr. Hari Dhakkal, and the other faculty members. And I'm handing over meeting to the chairperson, Dr. Hari. Dr. Hari, please uh, uh, handing over to you.
Dr. Hari Prasad, you're on mute, sir. Please unmute.
Thank you very much for inviting me and giving this opportunity to chair this session. And it's very important. And our respected program director, Madan Piya, Dr. Madan Piya sir, and chief guest, Dr. D.C. Doval, who is very known to us. And I would like to
Sorry,
invite
Dr. Madan Piya.
I would like to invite
initiate
Madan Piya sir to
further
start
room.
the program. I mean, I'll request him to. He's a chairman of the National Hospital and Cancer Research Center, Kathmandu, Nepal. I would like to invite him to take a mic and continue the program.
Namaskar, good evening, and especially Doval sir. I have been known Dr. Doval for more than 20 years, so we became like a friend. And rest of the others are my junior colleagues. I'm very proud to see all the names. Today, we are going to discuss about recent updates in diagnostics of solid organ tumors. As all of us know, that 90%, more than 90% of the cancers are from solid tumor groups. And nowadays, because of the modernization of everything, there are different types of tests are being available in the past. And in contrast, nowadays, everything has gone to the molecular level. And in addition to the molecular labels, also the hot topic seems to be genetic testing, which will be discussed in the later on. So we are mostly going to focus on different types of solid tumors. And the main purpose, why do we need to do genetic testing? So probably it will be discussed in details, but basically it is to find out the hereditary risk predictions or for differential diagnosis, treatment, monitoring of the treatment, or whether it is in relapse or not. And on top of that is a target treatment. So having said that, I would like to welcome everyone and our chief guest, our Dr. D.C. Doval. As I said, I've known him for more than 20 years. And I'm very happy to see him in pictures, although it is virtual, not physical, and to give his opening remarks. Dr. Doval, sir.
Thank you, Dr. Piya, and I think you can hear me and see me also virtually, though not physically, but year beginning is a time when you look forward that there would be a conference by Dr. Piya and we would go to Kathmandu. But since last 2 years, I think once we had 1 year before, but it was not, it was a short one kind of thing. And as Dr. Piya was mentioning, it's almost quarter of century, that about 25 years that I came to Rajiv Gandhi. It's 25 years for Rajiv Gandhi, and I think in the very next year, I think 97, 98, I got introduced to Dr. Piya, and we know each other almost for about 25 years. So, good evening to everybody, and it's my pleasure today interacting with the eminent faculties, oncologists from all over Nepal. It's a great pride to welcoming all the attendees present in the conference, and I'm grateful that they have taken out time, precious time for this meeting. The next few minutes or so, I'll be telling about the conference. I'll be walking to you through the conference proceedings and by how useful it is going to be for you. What does the future hold for us in the recent diagnosis of diagnostics of solid organ tumors? The world of molecular profiling has undergone revolutionary changes over the past few years as knowledge, technology, and even the clinical practice have evolved. Broad molecular profiling is now nearly essential for all patients and metastatic solid tumors, and comprehensive molecular profiling of patient has been widely studied over the past few years in a variety of cancer, leading to development of new disciplines named as personalized or precision medicine. So we are using molecular profiling everywhere, and two of the commonest examples we can take of the breast cancer and the lung cancer, and molecular profiling has now become a standard practice for most clinicians with advanced disease, replacing the histological management paradigm and prescribing standard chemotherapy based upon the tumor, origin of the tissue, and histology and the stage. The approach has allowed oncologists to recognize the way the cancer will be treated in the future, and nowadays lots of advanced tumors can be treated with great success even in advanced disease. In some cases, they have produced dramatic positive outcomes, including complete remissions, even in the setting of treatment-refractory disease, delighting both the patients and as well as caregivers. So molecular profiling is a rapidly evolving field. It's a time for us, the clinicians and the scientists, to meet need of the hour, collaborate with each other, and understand the science. I am very fondly reminded of one patient. In 2002-2003, we did a study which is known as ISL. ISL study worldwide nobody knows because it was a negative study. And this was mainly for the patient with lung cancer where no molecular profiling was done. We used to treat patients by, Asian origin, non-smoker, adenocarcinoma, and a female. If these four factors used to be there, we could prescribe them with gefitinib or erlotinib. So this ISL was a very big study. It was a worldwide study, and finally, what happened that the study failed, and we had one patient which was ongoing. The study was unblinded, and we found that the patient was getting gefitinib. So we had to procure gefitinib for this patient, and this patient went on gefitinib for about 13 years. We did not have any molecular markers for response to gefitinib till about 2007-2008. The patient was doing fine till about 2013. The patient died, in 2013, but before that we did the CT scan which had progression in the liver. We did a liver biopsy, and then it was found to be exon 19 positive. So it was a targeted therapy, right, that we were giving right from 2002 because of the patient had the particular molecular alteration. So this is a kind of success story that can be seen even in stage 4 lung cancer. Patient surviving for about 10-11 years is a success story by itself. I think with these words, I would welcome you all to this meeting, and I think it's a nice step on behalf of Core Diagnostics to educate the clinicians and us regarding the further management of the. But I think we are not covering BRCA. I think we are also taking up BRCA1, BRCA2 testing. I think that will be taken by Aparna Dhar. So I'll hand over the mic to Dr. Madan Piya for further proceedings, please. And wish you all the best for the new.
Okay, thank you, Dr. Doval, for a kind introduction. Now I'm going to introduce our chairperson, Dr. Hari Prasad Dakal. I don't think we need to go details about his degrees and other things, but one interesting thing I would like to share about him is the first, before starting a BP Cancer Hospital, I was in the management committee, and I was one of the person who recommended him for doing a postgraduate MD in pathology because he was a very bright student. I think he was a board topper in Bangladesh. So after that, I think everyone knows about his history. He has been to different countries and did his subspecialty in pathology and all the other related field. So without much wasting time, I would like to introduce Dr. Hari Prasad Dakal and do the further proceedings.
Thank you, Madan sir. Thank you for your kind words introducing me. And this is very kind of you. I know you for a long time, and you are my senior and respected Dr. Doval also, and also esteemed speakers of this session, this topic, and also the esteemed panelist and moderator, along with all the attendees who are listening and watching these programs. Today's very pertinent topic, recent updates in diagnostics of solid organ tumors. This is very important these days, as Dr. Doval has pointed out rightly. Earlier, we didn't have much molecular markers, much profiling, genetic profiling. When we started in BP Cancer Hospital also, even we didn't have a ERPR or to IHC, immunohistochemistry. Now, we have a plethora of tests, including molecular tests. So today's topics is very pertinent, updated version, recent updates in how we can be the specific for diagnosis of specific cancer and how we can tailor the treatment and how we can give the targeted therapy. This has been the talk of the today, and I think two pertinent, very esteemed speakers are there waiting to give the talk, and I don't waste the time. And I welcome all of you for this webinar. And first, Dr. Aparna Dhar, who is the head of the department, Medical Genetics and Genetic Counselor, Core Diagnostics, Delhi. She has been educated in the Mayo Clinic Medical College and also University College of UK, and then Glasgow. So she is a very eminent genetist and genetic counselor, and I would like to invite her to give for her special topic of today, which is very important for all of us working in cancer care, comprehensive genomic profiling for solid tumors. Where are we in 2021? I would like to invite Dr. Dhar to have mic and to for this esteemed lecture. Thank you.
Hi. Thank you. Good evening, everyone. Thank you, Dr. Thakur, for those very kind words. And it's lovely putting a face to the name. We've always had the pleasure of interacting with you. So it's nice finally getting to see you virtually. May I get my slides, please? Right. So good evening, everyone. Thank you, organizers, for having me here today and giving me this mammoth task of, shedding light on comprehensive genomic profiling in solid tumors. And where are we in 2021? So I'm going to try and keep it very basic, very simple. Obviously, there are a lot of solid tumors. I cannot shed light on everyone due to paucity of time. Otherwise, I'm going to be sitting here all evening. And I do know we have an amazing panel discussion and an amazing speaker. We have Dr. Shrestha after me, so we all want to hear him. So I'm going to try and shed light on the common cancers that we know and maybe some little uncommon cancers that we thought were really not molecularly very interesting. So without much further ado, let's get started. Next slide, please. So as physicians, you want information, right? You want this information early, you want it accurately. And the reason for that is we know that with patients with metastatic disease, the PFS gets shorter with each subsequent line of therapy. And in turn, this decreases the options for our patients. So you want to use the best therapy available. You want to be able to switch therapy as early as possible if it's not working. And one platform that has very slowly and steadily become extremely reliable to help address these concerns of physicians is next generation sequencing. So you cannot talk about molecular profiling and not, and talk about NGS. So next, please. And 2021, next slide, please. So in 2021, despite our increasing reliance on NGS technology in clinical cancer practice, previous slide, all too often the typical NGS flow looks something like this. Next slide, please. So we get a tumor sample from a patient, right? And then we send it off somewhere to some lab. And where this patient sample gets put into this, let's say this black box, something happens mysteriously. And as if by magic, a report gets, hopefully within time, gets generated. So while I say this half in jest, considering the differences that are there in the different NGS methodology, it becomes very important to actually understand what is happening in next generation sequencing, because the downstream interpretation is very, very important for our clinical practice. So for the next few minutes, it's going to be my task to help you unpack and unravel the mystery of this genomics black box to make its contents a little bit more accessible. Next slide, please. Right, so this is a basic overview. Please pardon my my animation skills over here. So we get your patient sample, right? The sample could be a tissue biopsy, which is in a formalin embedded block in those FFPE blocks. You could have a liquid biopsy when we cannot get a tissue and it's a metastatic disease. Liquid biopsy is an option where we look at the circulating tumor DNA, ctDNA, or basic germline testing where you take your patient sample in an EDTA tube. So what's the first step? We start with genomic DNA isolation. That gets isolated first. Then you convert these. You extract the DNA. That DNA gets isolated and then you convert it to a DNA library. Now, this library is a fragment. It's DNA, essentially DNA fragments. And it is at this particular step where we actually decide if this is going to be a 5-gene lung panel. Is this going to be a 500-gene foundation type panel? Is this going to be a 2-gene panel? It is at this point when we are making these libraries. Now, when I say the word library, what I essentially mean is I am adding adapters to the end of these fragments to make them more compatible with the sequencing machine. The sequencing machine, which essentially is my black box over here, converts the nucleotide biological information into digital information in the form of these large text files. Now, these text files consist of reads, and these reads are then processed through various computational analysis models, various softwares that help us identify and call out these genomic variants. And once we call out these genomic variants, we cross-reference them with various databases, and voila, a report gets generated. So it's essentially a full phase. There are 4 phases. The first phase is pathology, your wet lab. It goes onto the sequencer, which is phase 2. Phase 3 is your bioinformatics pipeline, which is translating all that biological information into a language that we understand. And then there's your clinical interpretation and the reporting. Next, please. Now, one of the key benefits of actually doing NGS is that it actually reveals the genetic heterogeneity of a tumor. And we know cancers, especially the metastatic types, it's not driven by one single mutation or one single disease, right? We know as the disease is progressing, it's becoming metastatic. It's not only heterogeneous, but there is continuous crosstalk between different functions and different pathways. And with next generation sequencing, we're able to identify these at one shot, at one go. Next, please. So as we move towards understanding what are options available, as Dr. Doval said, that back in the early 2000s, when we were not really using targeted therapy, but we knew that it had some importance. Between then and now, I just feel that these particular targets have actually taught us a couple of things. So I thought, let's look at the lessons that the targets have taught us. Next, please. So one gene is good enough. This is a beautiful example of a 38-year-old male, melanoma with subcutaneous METs deposits, and it underwent multiple lines of therapy. It failed. In fact, the last therapy was dacarbazine, barely had a 5% response rate. They sent this tumor in for molecular profiling. They found a BRAF V600E mutation, which we know is synonymous and the most common mutation with melanomas. And the patient was put on a BRAF inhibitor. And what we saw, well, as we know, a picture is worth 1,000 words. The patient has responded exceptionally well. Exceptionally well. So again, one gene sometimes is more than it can actually just do the job for you. Next, please. Second, targeted therapy is far more superior to patients than chemotherapy in those that are molecularly matched. And I love using these two graphs because in one case, they took a known EGFR mutation cohort where they put one arm was only chemotherapy, patients were given chemotherapy, and the other arm were given geftinib, which we know is a TKI. Similarly, they looked at patients with melanomas who had a BRAF V600E mutation. One cohort was put on chemotherapy, the others were put on vemurafenib. And what we saw, and these Kaplan-Meiers very beautifully illustrate that those who were molecularly matched, who were given targeted therapy, had an excellent PFS and OS versus their, those who just got chemotherapy. So targeted therapy is far more superior than chemotherapy. Next, please. Now, agnostic markers, what a wave, right? So over the last couple of years, we've actually had more and more data that is coming out and looking at agnostic markers. So it actually, what do we mean by agnostic markers? So it means markers that can be used with specific agents across multiple tumors. So it's essentially one target, one drug for all your tumors. And I've just compiled all the approved agnostic markers that are available today and those that are in the process of getting approved. Next, please. Now, two of the most common agnostic markers that we use, one is MSI high tumors, where you can actually give them pembrolizumab. Then similarly, patients with NTRK fusions, where you can either treat them with larotrectinib or entrectinib. And these waterfall plots actually illustrate that the patients not only had a very good OS and PFS, but what was very important was that across the board, across all solid tumors, the patients did respond well. Next, please. Then we move on to controversy's child, as I like calling it, is in June 2020, the FDA approved pembrolizumab for adults and children with a high tumor mutation burden. Again, this was a blanket approval that was for any and every type of solid tumor. But when we look closely at the data from the Keynote 158 trial, you'll see that there aren't really a lot of cases with respect to breast cancers, NSCLCs, even GI cases. So is it truly an agnostic marker? I'm not really sure. Maybe, we could have different cutoffs for different solid tumors, but that is a debate for another day. Next, please. The next lesson, multiple target testing actually is becoming important. And why is that? One target, one drug eventually leads to resistance. We know that EGFR is a classic example. I know we go on going back to lung cancer, but that seems to be the poster child for being the most molecularly diverse tumor. Then two, one target, one drug does not inform for more potent targets. That's actually very true. What we've started seeing is that if you look at lung, you look at colorectal, you look at breast, ovarian, when we start looking at more than 1 to 2 targeted mutations, and we start looking at a much more wider panel, we start seeing that sometimes the common mutation that we think should be the driver mutation is not the driver mutation. And there could be another mutation that is actually guiding and leading the tumor. And again, a classic example is because we're starting to do NGS, like in lung cancers, you're seeing EGFR, ALK, RAS, BRAF, MET, like upfront NGS basic panel. And a lot of times we're starting to see, while we want a patient coming EGFR positive, a lot of times a patient does come in addition to EGFR, we'd see an ALK mutation or an ALK fusion. And that ALK fusion is actually the driver versus the EGFR. So again, we need to start expanding this cohort and not just looking at one gene. And one target, one drug does not give you the whole picture. Sometimes when we do these, these extended panels, not even extended, but if you go a little bit beyond just that solid tumor, let's say a 50 gene, 100 gene panel, there are a lot of times that we find these passenger mutations, which honestly, they don't affect you. They don't guide therapy. But what they tell you is the tumor biology. They can tell you that with them, the presence of a TP53 with an EGFR is actually inhibiting your EGFR, your TKI. So your patient is not going to get the response that you're looking for. Thus it's becoming extremely important to, as much as possible, try and get the entire picture. To understand the tumor biology is extremely, extremely important. Next, please. So we know we have targeted therapies, but apart from targeted therapies, there are days we come back and it comes back blank, that we've not got any targeted therapy, we've not got any passenger mutation that could actually tell us how the tumor biology, or which cannot help us define what type of chemotherapy a patient may or may not respond well to. We do have the option of immunotherapy. Immunotherapy has three components to it. One is PD-L1. In PD-L1, we have three clones, your 22C3, SP142, SP263. We've had a lot of trials that time and again have proven that PD-L1 is a reliable biomarker for calling out a patient if they are eligible for a PARP inhibitor. Again, the TPS CPS cutoff scores from 2 to C3 will help define which patient should be and should not be given chemotherapy. There are different cutoff scores for different solid tumors. I think PD-L1 we've got a much more better understanding with that than we have with TMB, to be very honest. Second, MSI. I've already shown you the waterfall plot, which clearly showed across the board, if the patient is MSI high, they will respond well. They should respond well to immunotherapy. And then you have TMB, which, push come to shove, you don't have an option. There are in some cancers whose mutational burden is exceptionally high. They are going to respond well to immunotherapy. Sorry. Next slide, please. Another very important thing are those really, really hard to treat cancers where we really don't know what to do, be it your hepatobiliary type, be it your HCCs. So in cases like this, I think NGS becomes such an important platform because it helps identify, the profiling gives insight into the various biomarkers that could be potentially driving those tumors. While they may not be tier 1 with respect to targeted therapy, they're at least tier 2. So if you don't have any options, you can always try, especially in these very hard to treat rare cancers, using these targeted therapies. Next, please. So what does the molecular landscape look for 2021? Next, please. So let's start with how are we treating our patients in 2021? If we look at ourselves this year, we have the option of chemotherapy. You've got your molecularly targeted therapies, your NIBs, which are called the NIBs. You've got your checkpoint inhibitors, which is immunotherapy. And then you can also do a combination. So we've got a plethora of ways that we can today, treat our patients. So next, please. Before we look at the landscape, I wanted to very quickly show you this interesting study that came from the MSK group, where they looked at the mutational landscape of 10,000 patients with metastatic cancers by sequencing the tumors to look for druggable mutations. Now, a large cohort of patients, what we saw actually fell within the gastrointestinal malignancies. And when you actually look closely, you'll see that these druggable mutations, you've got your gastrointestinal stromal tumors, but also those really, really hard to treat biliary or pancreatic cancers, or the extremely, extremely hard like HCC. All of those HCCs, like hepatocellular carcinomas, you will find a lot of targets. So the more that you sequence, and what this study showed was that the more you sequence, you got exposed to more targets, and essentially improving your options and the druggable options that could be available for your patients. Next, please. So I was talking earlier about how tumor mutation burden is, technically becoming an agnostic marker. And this was a continuation of that study. And what we saw was that if you look at the slide, you can see patients, especially those with GI cancers, pancreatic cancer, had a very, very high mutational load. So, this is just evidence that a patient may eventually respond well to tumor mutation burden. And it was very beautifully illustrated in this paper. Next, please. let's come down to the molecular profiling that we all are very, very familiar with and also very fond of. We know that upfront when a patient gets diagnosed with NSCLC, stage 3 and above, we send it in for molecular profiling. I think this is one cancer where I've never had to argue with a doctor and say, please send it in for molecular profiling. We'll think about chemotherapy. You know, it just very automatically was the patient's diagnosed. As soon as that pathology report came, adenocarcinoma, NSCLC, the patient was immediately sent for molecular profiling. And what started off as just EGFR ALK ROS1, as you see, slow and steady, these biomarkers are increasing. We've got BRAF, MET, NTRK, RET fusions. And if you look at EGFR ALK ROS1, we've got first generation, second generation, in fact, even third generation of targeted therapy that is available. So with respect to NSCLC, I think this is possibly one of the most fastest evolving molecular profiling, one of the most fastest evolving cancers that we have today with respect to molecular profiling. Next, please. So around 2 months ago in May, I was presenting, the updates in NSCLC, and I just made a statement that, be on the lookout for KRAS and EGFR HER2 exon 20 insertions. And as we know, in 2021 June, the FDA did give approvals for targeted therapy for these two. So again, while look at the incidence rate. The KRAS is 13%. Your EGFR HER2 exon 20 is 2 to 4%. That's a pretty large cohort. So again, as we evolve, as there are so many trials, clinical trials ongoing, which is resulting in these patients, which is resulting in giving us more options for targeted therapy. Now let's move on from NSCLC2. Next, please. To ovarian cancers. Now, ovarian cancers, 3 very straightforward ways of doing it is chemotherapy. We know patients are put on platinum, taxanes, and there are other options too. Push come to shove, if you have no other option left, immunotherapy can be given. But the key targeted therapy here is your bevacizumab. You've got your PARP inhibitors and your NTRK fusions. Now, I want to just talk about the PARP inhibitors for 2 seconds. Next, please. So PARP inhibitors are given to patients where they have ovarian cancer patients who have a homologous recombination deficiency, which means that there are 2 ways of scoring this. One way of scoring this one way of doing this is looking at all the genes. And as you see the HR deficient in this pie chart, around 50% of ovarian cancers fall within that cohort. And that means that there are around 16, 17 genes whose key role in the DNA damage repair pathway is to perform homologous recombination repair. And if any of those genes have any sort of mutation, that means that the cell is obviously, it's not going to be able to perform its function, which is homologous recombination repair, which means it's going to become homologous recombination deficient. Now, ovarian cancers, 50% fall within that cohort. And in that 50% cohort, irrespective if it's germline or somatic, they don't say the propensity, it's more common that we see patients in germline setting coming positive for this mutation versus somatic. So one of the key reasons I actually wanted to spend some time on this was that with ovarian cancers, as soon as a patient is diagnosed with ovarian cancer, irrespective of histology, today guidelines recommend that if not somatic, at least up front, irrespective of age, family history, I think it should become a practice. It should be part of our clinical practice that patients get sent in for germline testing. And germline testing ideally should be done. Yes, BRCA1, BRCA2 are the most common, but you've also got your other CHEK2s, your PALB2s, your RAD51Cs, RAD51Ds, which are so very important in that entire pathway. So do get your patient checked for germline testing. Do an MLPA if that comes negative, MLPA for BRCA1, BRCA2 for your large deletion duplications. And when the germline is negative, which means that you've done 100% coverage, then come on to somatic cancers, then come on to do somatic testing. And, then we can take it up from there. But this is about ovarian cancers. Next, please. From ovarian cancers, let's move on to breast cancers. We know with breast cancers, it's not just about breast cancer as a disease. Breast cancers are classified based on the ER/PR HER2 status. So let's look at the first one, the triple negative breast cancer type. So what I've done here is a little bit of what is there today and what do you do in a worst case scenario, or what could potentially happen. So we know that if a patient tests positive for androgen receptors, we know that there's targeted therapy available. Again, you've got your inflamed phenotypes, which is essentially your immunotherapy or checkpoint inhibitors. Any damage in the DNA repair pathway, which means a mutation in the homologous recombination repair genes, especially the BRCA1, BRCA2, the patient can be given a PARP inhibitor. But here one has to be very cautious, is that in TNBCs, only germline, today what is approved is germline BRCA1, BRCA2. If a patient tests positive, if a patient has a mutation in BRCA1, BRCA2 germline, they are eligible for a PARP inhibitor. The rest is more from, is actually in clinical trials, and hopefully by the end of the year or early next year, we will get approvals for using them across the board. But one thing I want to highlight is that even patients who do have a mutation, germline mutation in the BRCA gene, or they have in any of the HRR associated genes, what is extremely important is that these patients will respond well to platinum therapy. So upfront, sometimes even in ovarian cancers, in fact, even in prostate cancers, this sort of testing can actually help guide how are you going to look after your patient, and also help guide what would be the ideal chemotherapy of choice for your patient. So apart from that, we've got your PIK3CA, sorry, there's an error over here. You've got your PIK3CA, AKT, PTEN, these alterations over here. We do know that we have targeted therapies. We have, mTOR, we've got inhibitor, we've got therapy that inhibits the mTOR pathway. And again, you've got your HER2 mutations, you've got NTRK fusions, RET fusions, which are not HER2, but NTRK and RET, which are coming out to be agnostic markers. Next, please. Then let's look at the HR positive, the hormone receptor positive, which is essentially ER positive, PR positive, and HER2 negative cases. We know we've got ER, PR as a standalone, but one of the most common resistance mutations to ER is ESR1 and a PIK3CA mutation. I seem to have made an error again. Sorry about that. So ESR1, we know that if a patient acquires this resistance mutation, they are not going to respond to aromatase inhibitor and should be immediately put on fulvestrant. And similarly, if a patient does have a PIK3CA mutation with that, a combination of fulvestrant and alpelisib, we've seen from the SOLAR-1 trials, patients have had a phenomenal response. In addition to that, again, be it the DDR pathway or the other genomic alterations, this is work in progress, but in the long run, they will eventually come into our clinical practice, daily clinical practice. Next, please. So this is a very quick screenshot that we have of our where we are with the CRC model, but we also know that when a patient does progress, we can re-challenge them. We've seen it in the Montague trials, we've seen it in the Cricket trials, that patients can be re-challenged with, for those who have a RAS mutation with an anti-EGFR therapy. So there are a lot of therapies available. Here you've got the NTRK fusions, you've got MSI, HER2, your BRAF, and your RAS wild type. And next, please. So I thought let's talk very quickly about gastric and esophageal cancers. We know that the patients who fall within this group have a very interesting genomic roadmap. And we also know that the targets include HER2, MSI, and the Epstein-Barr virus, that can actually help guide therapy. But we know that with NGS, what they saw was that if a patient underwent NGS, it actually increased the cohort, it actually increased the chances of identifying a potential targetable biomarker from 15 to 25%. Again, they may not be tier 1 approved, but at least tier 2 approved. So I just realized I'm going tier 1, tier 2. So tier 1 and tier 2 are based on the AMP guidelines as to how we call out a somatic mutation. A tier 1 essentially means that, we found a mutation in a particular biomarker. It has an FDA approved therapy for the tumor that you're testing for. A tier 2 is that you have a targeted therapy for a particular biomarker with an approved FDA drug, but not for the tumor that you're testing for. But push come to shove, in a lot of cases, when you hit the end of the road, it's not a bad option to try and apply tier 2. Obviously, you have to look at all the clinical implications. I'm not denying that, but there are options that are available. And the most interesting thing that I found is that with respect to gastric esophageal carcinomas versus all its other GI counterparts, it's possibly one of the most heterogeneous cancers. It beats even lung cancer. And the reason we don't talk so much about it is because when we do the molecular profiling, we're just limited to HER2, MSI, and maybe the EBV. So in the long run, as we start going and leaning towards comprehensive genomic panel testing, we go beyond the tumor specific and we start looking at larger panels, we will start getting more data with respect to these cancers and more targeted therapies that could be an option for these patients. Next, please. So let's look at the biliary tract cancers, right? So this was once upon a time a homogeneous, boring disease that was usually treated with gemcitabine and cis for over 10 years and nothing else. And then you had second line, which, where they approved FOLFOX. But the outcomes were obviously very limited. Now, in 2021, we've actually started seeing that this is a very heterogeneous, genetically driven disease. Not only anatomically between intrahepatic and gallbladder, but we can actually effectively get clusters based on certain iterations. So you've got your FGFR2 fusions, you've got your IDH1 mutations, and these go into the intrahepatic. And then you've got your HER2, which we tend to see more with the intra and the gallbladder cancers. And again, then in between, you've got your BRAF mutations, NTRK, MMR. So we started increasing widening the genes that we started sequencing for our patients with these cancers, and we started getting more targeted therapy, which resulted eventually in 2020, we got FDA approvals for FGFR1 with, I think it was pemigatinib was the drug, and ivosidenib was for IDH1, which was an IDH1 inhibitor. So we are getting a lot of options. Next, please. Now, when we think of pancreatic cancers, once upon a time, molecularly, KRAS used to top the list as the most common mutation, and it was historically deemed as being very molecularly monotoned. But like I said, again, you start, increasing the cohort of patients, you start looking at, you start increasing your molecular profiling, and what we saw was that there were actually so many actionable mutations that we could see for patients with metastatic pancreatic cancers. In fact, 17 to 48% of these patients could actually harbor any of these actionable findings, while the HRR genes, were topping the list as being one of the most common. But in addition to that, you've also got your FGFRs, you've got your TOP2A, your STK11s, you've got genes in the mTOR, AKT in the pathways, you've got your RET mutations. So while we don't have prospective randomized clinical trials for these particular targets, but they were, because pancreatic cancer is such a hard to treat tumor and with such a bad prognostic outcome, the NCCN in 2019 has actually written it well into their guidelines. And this is where we are with respect to pancreatic cancers. Next, please. Now, while it all seems all great when we talk about molecular profiling, there are a lot of mutations present, et cetera, there are certain challenges that we do experience in our clinics, right? So one is the obstacles of using genomic finding, which is cost of testing. Even a small 5-gene panel, which may seem to be cheap, may not always be affordable to our patients. And just because the testing may be affordable, the drug may not be available, or the patient cannot afford that particular drug. So tumor heterogeneity, we know that in metastatic advanced cancers, as the disease progresses, it becomes extremely heterogeneous. And in an ideal world scenario, you want to do a combination of tissue and liquid biopsy, because that will give you, you're covering all your corners, but we know that's not possible because, again, cost is an issue. And then what happens if I found a mutation in germline and I did not find that mutation? Like if I see a BRCA mutation in germline and a BRCA mutation in somatic, which one is more lethal or pathogenic? There's so many unanswered questions. And also, is the efficacy more for my drug if it's germline or somatic? These are, again, some unanswered questions. What happens if you get a VUS? Strong family history. Patient is a known case of ovarian cancer. I find a BRCA1 VUS. What do? I've run out of options. How do I treat my patient? How do I explain to my patient that VUS is, We really can't take any clinical decisions on it, irrespective how strong your history is, or no matter how tied up or how pushed back in a corner you are. You sometimes cannot do that. And these are some of the key challenges we face. In addition to that, it's also about there's a limited awareness regarding molecular testing and what are my treatment options.
Dr. Dhar, can you summarize?
Yes, I'm just, this is my last slide. I'm not doing the case studies.
Thank you.
Yeah, sure. And last but not the least, I think one of the key practical challenges that we face is that understanding and interpretation of these reports. That becomes a huge challenge for us, especially when we see multiple driver mutations, or we see mutations that we really cannot identify, and we're not able to link them to, because there's no targetable mutation, we don't really understand what's their role in the pathway or with the tumor or with the disease. So at junctions like this, next please, I think one way of tackling this is very important to get on board a geneticist or a genetic counselor to help weave you through the complexities of these reports. And also, I think understanding the whole story is important in understanding what type of testing is required, what components are required. Do I really require germline testing, or can simple IHC suffice? Should I do RNA testing, NGS? How do I go about doing it? And I think it becomes extremely important of us understanding this to try and reduce the challenges that we face in our clinics. Next, please. So can you just go forward to the last slides, if fine, please? Just go next. Okay, I was just going to go, yes, thank you. So just to very quickly summarize and conclude that NGS is, I think, an extremely important platform, especially as we are headed towards this whole wave of precision medicine and where molecular testing is so critical for our patients to help decide the key steps forward. So I do think that NGS is number one. We have to get that on board, get a geneticist or a genetic counselor to help you deal with these complexities. And last but not the least, I do want to reiterate that I did mention on tumor mutation burden. Yes, it is slightly experimental, but push come to shove, you could possibly opt for it. Next, please. And on that note, thank you so much for your patient listening.
Thank you, Dr. Dhar. It is difficult to comprehend all things in just 30-40 minutes time. It's very concise and very informative, but it's a very new chapter. So you have mentioned that tumor heterogeneity is a big issue, and that's why single marker may not be effective for long-term treatment in cancer. So it's a more of multiple markers, multiple targets are essential. So only this in this 21st century, and in this third decade of 21st century, we have this comprehensive genomic profiling, which is promising future, but cost is issue. So this is a tumor heterogeneity, and only one essay giving the lot of information for diagnostic, prognostic, and predictive markers. And especially you have mentioned, I think all the audience must have heard agnostic marker. One marker can be applied or can be used another one from one organ tumor to another organ. So like HER2 from breast to coming to lungs and stomach. So this is important. So very nice message you have given, and question answer will be at the end of the session. So I'd like to invite, thank you very much for your elaborate, very nice lecture, informative lectures and wonderful. And I would like to invite our next very eminent speaker, and everybody knows him. He is a very well-known personality, and Dr. Sudip Shrestha. He is Executive Chairman and Senior Consultant Medical Oncologist, Department of Medical Oncology, Nepal Cancer Hospital and Research Center, Harisiddhi, Nepal. He has 25 to 30 minutes for his lecture, and his topic is in beginning of new era in cancer care. It's CGP, comprehensive genomic profiling, a way forward, what a clinician should know. So I'd like to invite him to give and to finish his lecture in time. Thank you.
Thank you, Dr. Hari. At the outset, I'd like to thank the core diagnostic and our host, for giving me this opportunity. I would like to thank my mentor, Dr. Doval, to being a chief host, and also my senior colleague, Dr. Piya, as a program director. Respected dear colleagues, these topics for me today is regarding this comprehensive genomic profile. So let me share my slide from here. Is it visible?
Yes, sir. We can see your slides. Put it on a slideshow mode.
Okay. Is it visible now?
Yes, sir.
Am I
Please go
audible?
ahead. Yes, sir.
Fine. So we have just listened Dr. Aparna regarding how this comprehensive panel and genomics has been used in clinical settings, especially while managing a solid tumor. But we, as a practicing clinician working in low or middle income countries, scenario is different. And especially in our setup, when we are working in private, we have a different spectrum of the patients who comes to us. Most of them can't afford. Some can afford. Some wants to do best. So in such scenario, it is very, very difficult. And moreover, now it's the era of this informatics. Everybody knows about everything. And even our patients has become very, very smart. They come out with different drugs names. Probably sometimes you may not heard of it. They might have come with a different diagnostic tool. They might have not heard of it. So it is always for us to be smart enough to know everything, especially in our era regarding the molecular genomics, because this is now the future, what I think. So let us start this molecular genomics with the eyes of the clinicians working in low to middle income countries, how to proceed. So we know that, let's imagine that we have one day we are sitting in the clinics and the patients with some cancers comes to you, and we do some molecular profiling of the patients, and we stratify the patients by different biomarkers regarding their diagnostic, prognostic, and predictive markers, and we identify one drug which is very, very effective, and patients walks away with that medicine. So now this is no longer a science fiction. The things are happening that we know it now. So with the development of this molecular biology in recently, now this molecular biology has become a breeze from bench to bedside. Now, there has been a lot of development in biotechnology, digitalization of healthcare, and public investment recently coming up. There's more and more people are investing for this science, and it has led to evolution of personalization of disease-based therapy. If you see the economics regarding this molecular diagnostics and therapeutics, like recently in 2019, the data shows that 46 billion in US dollar investment has been pumped in for this market. But the things is going to rise. In 2030, it is expected that $148 billion will be invested. So that much amount has been pumped. So definitely, probably this science will be the future for us. Recently, we heard from Dr. Aparna that how we can use this science in 2021. So in our setup, when we work in our clinics, let's see how we have to practice in spite of we have a science, but there are a lot of limitations. So let's see with the very common cancer who come to us. So this is a one female who is a 56-year-old non-smoker who is presented with a cough of 3 weeks with chest pain. Initially, thinks that she attends some local clinics, and she had some anorexia and myalgia, and she was treated there with some antibiotics. The things doesn't get better, and then they comes to line up with some hospital, which is a hospital where they have a CT scan. So now things has already moved up to 6 weeks. No, they have found something in the CT scan, and the doctor was somehow little smart, so they did FNAC, and diagnosis unfortunately came as a carcinoma, most likely non-small cell lung cancer. Now the patients If they have an approach, they have a facility, they come to tertiary care hospital or cancer hospital. The things has already late. Now it is nearly 2 months. Now they come to some cancer hospital. They undergo some bronchoscopic biopsy, and it is unfortunately again we are in dilemma. The report comes as poorly differentiated carcinoma, and it has been advised IAC. So 2 weeks, 2 months already been lost. So now what happens to as a clinicians? Now patients are symptomatic, patients are desperate, family are anxious and frustrated. Now we have to do something. We have only diagnosis left is that we know that is a lung cancer. It is probably non-small cell lung cancer, but we don't know it's adeno or histo. So what to do? So we did. But now we have a very little people have access to this genomic profiling and other tests, which is usually going to take another 2-3 weeks. Now then we have to start on something. So with the relevant data, probably you may be in a position to start chemotherapy, which we usually sometimes do it also. Now, since it is a polydiploid carcinoma, if you are very little smart, you don't want to be, so then you probably use the paclitaxel because it works both the way for squamous and non-squamous. So, but if pathologists give it, it could be adenocarcinoma, probably you might be starting PAM and JAM. Now again, as per pathologists as advised, IAC was sent, and but again, whether to send EGFR together or not, because sending both together is too costly. And if it comes squamous, then or sometimes it comes something else, or then the small cell, then EGFR may not have some role. So that way it becomes dilemma whether to ask your patients to pay both or not. So sometimes we do only ISC, sometimes we have to send IGFR as well, depending upon the patient's condition and affordability. And then, so by the time you have already lost the time, now after 10 days of waiting, or 2 weeks of waiting, the EGFR reports comes as EGFR negative. Now what else? Because again, you haven't sent ALK and ROS together because it is costing too much by PCR altogether panel. And then, but if EGFR comes negative, positive, then again ALK ROS sometimes become a waste of money. So you want to save the patient's money, then that's the problem. So again, now you are wasting more time. So now probably you need to start somewhere. That you are sending again after convincing the patient that there is a 7 to 8% chance of having ALK fusion positive in your case, or ROS. If you have this drug positive, you may be given targeted therapy. You may not need chemotherapy. Just send it. Patient agrees and send it. So again, the dilemma is to do PDL1 or not, because again, as per NCCN guideline, you do it PDL1 if only if this targeted therapy is negative. So if you have to send it again, then again sometimes it will be the cost will be tremendous. Now, sometimes you do send PDL1 also. The report came as now PDL1 less than 1%. So what next? Now again, it has already 17 weeks over. Now the patient is symptomatic. Now we decided to do some progression this evaluation. Now we found disease progression. So it is a preference that, but patient preference status 2. So what next? So the things now is that we have a patient who has progressive disease with first-line chemotherapy, and he has no targetable mutation, which is commonly done conventional targeted mutation. And the patient is immunotherapy naive and first-line chemotherapy. So what next? So second-line chemotherapy, if you go by the NCCN guideline, you have an option of either going for docetaxel or other combination, other drugs, single drugs or combination, or you can use, since is IO naive, probably you might use IO as well. But here, as PDL1 is negative, then probably instead of pembrolizumab, you may be using the nivolumab and atezolizumab, because pembrolizumab needs, if you want to use single, then you need PDL1 more than 1%. Then comes as per recommendation, that even for the immunotherapy to start, you should have at least the following these broad range genomic profiles. That is EGFR exon 19 deletion, then EL858R mutation, ALK, RAT, ROS, RAT, BRAF, MIT, and 14 MIT exons 14. All these mutation if possible, has to be found. If it is there, then because if the patient having this mutation may not do well with the immunotherapy. So probably before starting this expensive immunotherapy, probably you like to do all these mutations. But again, should you wait that long to have all this by doing the limited profile, genomic profile? So again, this is a dilemma. So this, in spite of, in the middle of all this dilemma in 2021, so what do? We try to see the NCCN guideline. So it says now that you should do broad molecular profiling right in front before you start your treatment, because all this mutation is possible by doing the broad genomic profile only rather than one. So that means again there comes the roles of either the targeted mutation or this comprehensive genomic profile. So that is the scenario. Probably we might be doing this, but again the cost, availability, and the financial things is another way. So this is a little crowded than this slide where you will see lots of things, but basically it is a molecular testing algorithm which we can do it for the non-small lung cancer metastatic disease. But here, if you see, there are star, red color stars is there in many places. What does it indicate is that wherever this red star is there, these are the place where you probably can consider comprehensive genomic profile. So these are the area, and the orange box are for the genetic. This is a test where you can use your conventional method, or you can use or hotspot or targeted genomic profile. So these are roles of comprehensive genomic profile everywhere, even before you start your treatment in the first line, or even after you starting the treatment. Once the patient's progress, probably you can use this CGP. So there are different methods of detecting genetic aberrations. This is genomic aberrations in the diseases. So these are just for the screen, just to recapitulate few of the tests. There are the capillary electrophoresis, mass spectrometry. These are the tests to detect biochemical changes secondary to aberrations, the genetic aberration. You can use ISC or FISH to detect again the protein due to aberration, or you can use RT-PCR to find mutations. And now the hotspot NGS to detect the genetic defect, multiple genetic defect, and CGP, that is comprehensive genomic profile, which is the talk of today's development. So this table will just show you the difference between this comprehensive genetic profile and other conventional tests which is done. Just for the student again, as we know that for any cancer, there are the 4 types of mutation or the genomic alteration happens to cause the cancer. One is base pair substitution. Second is either insertion or deletion. Third is copy number or alteration or rearrangements. So CGP is a technique where all these 4 mutations can be detected. So that way you may not miss any mutations which will be sometimes clinically relevant. So just to have some idea how to differentiate, how to know what is the difference between this comprehensive genomic profile and the test what we used to do before. So as I said, there are the 4 mutations which is done, and these are the tests which can be identified by comprehensive genomic profile. And there are some example. For example, for base substitution, you can have a BRAF mutations. For insertion and deletion, GFR exon 19 deletion, copy number, HER2 amplification, rearrangement, ALK fusion, and that is biomarkers for immunotherapy. And that is the tumor burden, metastatic burden, and MSI, which has been already discussed. So how this is a simple schematic diagram to understand comprehensive genetic profile. So there is a DNA which has a sequence, and there are the different color mutations. So by doing comprehensive genetic profile, you can detect all these mutations which can cause the cancer. But when you are using single gene testing, but here you are identify only one mutation or only within one gene, 1 or 2 mutation in one gene. So you are missing out so much gray zone. So that way, single gene mutation, you might diagnose disease, but you might miss sometimes some targetable mutation as well. So what is the multi-gene hotspot test? So multi-gene hotspot test is Here you can detect multiple mutations in the multiple genes, but it is the gene mutation is already known. So you have a marker, you can identify, know what you are going to look for this. And when you do gene sequencing, you try to identify those mutations by the different techniques is done, and you find out. For here again, doing multi-spot gene, you are missing out the things which is being picked out by comprehensive genomic this thing. So you by comprehensive genomic profile, you are picking up all the, the mutations which is not picked by other sequence. So by having your this is a molecular subtyping of the lung cancer which is done nowadays. Here the different mutations which you are listed out, you can do it by hotspot targetable gene mutation. You don't need CGF for this, because these are the known genetic mutations which is has a targetable mutations. So you can have this test done by using simple targetable this genomic profiling. But so what happens? What is the data? What do you get benefit by doing CGP? So by doing CGP, this is the one important slide to understand the advantage of CGP over hotspot genomic profiling. So this is a little crowded, but just to make you understand that if you do the test, like even for lung cancer, by hotspot test, but there is a chance that you are missing out a targetable mutation by like up to nearly 26%. So is a huge number, and there are lots of trial going on regarding targetable drugs, which can be picked up by CGP, but not by hotspot. So you are missing out this huge number of patients if you depend upon only hotspot. So comprehensive genomic profile will be better than hotspot test in some occasion. So this comprehensive hotspot test does also give you the complex predictive biomarkers for immunotherapy, which has been already done. So regarding TMB, I don't want to go too much detail due to lack of time. Again, as I said, TMB by comprehensive genomic profile, you can find out, you can detect, and similarly the MSI. So, but MSI also can be detected by ISC and also by PCR and also by these NGS, that is next generation sequencing. But what you have to remember is that identify SI by ISC is not equal to MSI. What does it mean? That by detecting MSI by PCR is functional detection of the MSI. So if you detect MSI positive by MMR, you have to confirm it by PCR. So that's what we do it for colonic cancer and lot of other GI cancer where MSI is positive. This immunotherapy is available. So there are different advantages of GCP. Dr. Aparna has already mentioned about that. So this is one of the tests which probably by chance we could do it on one of our patients. This patient was diagnosed case of advanced CS gallbladder and was treated elsewhere with first and second line chemotherapy. Unfortunately, disease progressed. Patients had is a good performance status and they are well-to-do family. They came out with the information that there is something called comprehensive genomic profile or next gen sequence available. So they want to do it and please let me do it. So with their request, it is done under Foundation One platform. So what is found is that here this MSI, this is reporting pattern which is given for CGP. So there is a macrosatellite is stable. So that means you can't use immunotherapy. Tumor mutation burden also less than 1 mutation per megabyte, million base pair. So that also is negative. So you can't use immunotherapy. So you have only two mutations. In one is one IDS1 and one is ARID1, two mutations. Out of that, ARID1 doesn't have any trial or anything drugs, targetable mutations, targetable drugs available. But IDS1 mutation, there is a drug available for leukemia, AML. AML having IDS1, there is a FDA approved drug, iboctinibi. Is a drug which is available, but not for the gallbladder cancer. But again, there is a phase 3 and phase 2 trial for cholangiocarcinoma. This drug has been used on there in a trial. So this information we have shared to these patients, and we told that this is a drug available, and this drugs we don't know it's going to work on you or not, but this drug works for leukemia, and cholangiocarcinoma. Having your gallbladder cancer is of same family. I don't know, it might work to you, but we don't know. The patients, and we also told that this drug is very expensive. We don't know its toxicity profile, and it takes time. But the patients said, we want that drug. And just to mind you, the drug costed $30,000 for 1 month. And he said he will get it. He ordered it and from USA. And the drug was taking time. And he said, I want to have that drug. He flew to USA. And last week he called me that I started taking that drug. So there are the patients who can come with this kind of things as well. So that is the scenario. So this is the drugs which is being used. Then other thing is having all this saying all these things. This looks very fascinating. This platform, this drug availability of drugs and these things. But again, this is not that easy, as Dr. Aparna has already mentioned. This is very complex. These are black box things because there are so many things that goes on within it. There are lots of scientists who play the role. Lots of things which happens before the reports comes to you, and there are a lot of challenges before from report to sending a report to the coming to report and its interpretations. For that to have a better advice for the patients, you should have a molecular tumor board. That is a concept of molecular tumor board, where you should have oncologists, research scientists, bioinformatics, pathologists, medical genetics, genetics counselors, and genomicists. So these are the people where you should have a board to have a good interpretation of your result and give the benefit to the patients. So having said again, so is it now the right choice? Should you go with this comprehensive genomic profile from the day one itself? Because always there's a tissue of issue, and there's also time is a problem. Because by having comprehensive genomic profile, you can have all the tests within a few weeks and with a small amount of tissue. So that is the benefit. You don't want to waste your tissue by doing a lot of tests in seconds. So is it the right way to do it? So again, there's one regarding one of the trial which is done in 2018 was reported in JAMA, says that in non-small cell lung cancer, doing this CGP and this targeted gene doesn't add on to survival. So that is 2 years back. But what is now? So what is now is little different, because as I mentioned that CGP can give the informations where you can have a better options. So with the better options, that like again, Dr. Aparna has already mentioned, there are so many new targetable drugs as coming up, where by doing the CGP, you can find out those drugs. Some patients you can put them in clinical trial. Some patients you can get the drugs by uncompensated background free of cost, and you can offer to them. So having doing this test is not always a waste. So this is a complex procedure what it goes on. So this is a procedure which Dr. Aparna has already mentioned. So as I mentioned, so you have to know when to send this CGP and how to take this benefit. So there are different clinical scenario where this can be of benefit. So could be now in the future. Before, what we used to do is when we used to send the patient's tissue for next gen sequence, when you don't have any options, you have treated heavily due to patients and you don't have option, you want to find some targeted drugs which can work for the patients. So that was the scenario before. But now probably is it where we should do NGS immediately once the patient comes to you. So probably yes in future. But by 2020 we have a comprehensive genomic profile. So that is coming up. But in future there are lots of work going on, more advanced biomarker detection by exome genome genomics, and transcriptome is RNA genomics and multi-omics. These all things is happening very quickly. And as I already said, there are billions and billions dollars are already have been invested. So things is not very far that we do this thing, and one day we'll come out with this kind of report that patients comes to you, and you have studied 20,000 to 25,000 gene of human genomes. You have studied 1,000 RNAs. We have studied protein 10,000 1 million proteins. Then you come out with drugs which is most suited for the patients. So at the end, I just want to conclude that with a better understanding of molecular biology of tumor, with digitalization of health care and available financial resources, personalized medicine has to be reality, has become a reality. Though it has become increasingly available for our routine clinical practice for developing world, it still hasn't been within the reach of all. It needs to be judiciously utilized, and definitely in future, it might be our dream come true. Thank you.
Thank you, Dr. Shrestha, for your very concise and informative from clinical perspective and from oncologist point of view, what is present and what is future. And we have time constraints, so I would like to invite Dr. Saugat.
Can I have a small comment?
Yeah.
About the just one comment. Dr. Sudip, I encounter one patient.
Dr. Gopi,
yeah.
I think we have a question answer sessions at the end of the panel discussion. If you want to comment on that, okay?
All right. Thank you. Thank you.
So I would like to invite Dr. Saugat Paudel, who is consultant radiation oncologist in National Academy of Medical Sciences, Nepal, as a moderator for the panel discussion, case-based panel discussion. I hand over my mic to him, and please, Dr. Paudel, it's your
yes. Thanks a lot, Hari sir. Respected Piya sir, respected Chief Guest Doval sir, all senior colleagues and my fellow colleagues. So with your permission, I beg to start this session. So is the slide visible?
Not yet, sir. Yes, we can see your slide, sir.
So let me introduce you to the panelists. First, we have on a panel, Dr. Gopi Aryal, who is Chair, Department of Lab Medicine and Pathology, Nepal Medicity Hospital, Nepal. Unfortunately, we had Baral sir as well, Dr. Rajendra Prasad Baral, who due to some personal issues could not come here. We have Dr. Prafulla Sakya, Consultant Breast Oncoplastic Surgeon from Nepal Cancer Hospital and Research Center, Nepal. We have Dr. Kapendra Shekhar Amartya, Head of Department Surgical Oncology, Nepal Cancer Hospital and Research Center, Nepal. So actually, when I was given the invitation for the webinar and I glanced upon the agenda and went through the list of our heterogeneous panelists, a pathologist, clinical oncologist, oncoplastic breast surgeon, surgical oncologist, I thought it would be prudent to include a case study and try to discuss various aspects of its treatment that crosses through the spectrum of our panelists that I have been provided with. Unfortunately, one of our panelists, Dr. Baral, is not with us due to some personal issues. However, I think we'll try to make it up. I'll put the question forward to Dr. Prafulla and all. We have quite an experienced listeners here as well. Our chief guest, Dr. Doval, we have a lot of experience to listen from him as well. So we may be needing your help as well. And Dr. Sudip, we have you as well. So with this, I'd like to proceed ahead. Let me walk you through a case study. So she is a 42 years female with no comorbidities, no family history of breast cancer, who noticed a lump in left breast for 2 months. So it was a clinically node positive disease, and FNAC was suggested by adenocarcinoma. Somehow outside she underwent MRM. So the histopathology report was an IDC 3 centimeter, a grade 3 tumor, 2 out of 14 node positive. The LVI was positive. It was a triple negative tumor with KI 67, 40% high. So moving ahead to Dr. Gopi. Dr. Gopi, you see, like whenever such kind of patient, when they come to us, a young lady, triple negative, like there's always a feeling among the oncologists. We just hope, I mean, that the triple negative is quite false. Maybe we missed it out on some point. So could you elaborate on some of the reasons for a false positive ER or PR and some of the strategies to mitigate this false negative?
Dr. Aryal, you are muted. Please unmute.
Thank you, Dr. Paudel. Yes, I think we have to consider some pre-analytical variables when you talk about the ISA procedure itself, because you know, there are so many factors like sample adequacy. For example, if you have a core needle biopsy of invasive ductal carcinoma where you don't find the normal glandular fragments, which is taken as internal control, so internal control and external control is very, very important when we do ISA. In my experience, when we retrieve the antigens, optimization is very, very important. Similarly, like during the antibody retrievals, we apply the heat. So we need fixed temperature, which is again need to be optimized in particular environment. There's no hard and fast, like in Medicine Hospital, I have one temperature. In Cancer Hospital, you may have another temperature. So
absolutely.
Optimization is very, very important. So pre-analytical variables, sample adequacy is very important. After all, we have to follow ASCO guidelines, ASCO. We have a recent guidelines in 2020, I think, where they talk about the initial quality controls and percentage of cells, positive nuclear staining cells. So if you follow the strict guidelines, ASCO guidelines, plus pre-analytical variables, plus sample adequacy, I think we can minimize the false positive or false negative result.
Fair enough. I think.
Yeah.
So let me move ahead. So exactly the points that you have highlighted, I have again mentioned it here. So some of the mitigating strategies, yes, of course, looking for the internal controls, the external controls, as well as I think correlation with histologic type and the grade of the cancer. I think that's important as well.
Yeah.
So moving ahead, so this is a question to Dr. Kapendra, who is a surgical oncologist, and Dr. Prafula as well. First, I'll be asking Dr. Kapendra. So for such patients, if you had the patient beforehand on the first hand, would you send such patients for neoadjuvant chemotherapy rather than upfront surgery? Dr. Kapendra there?
Yes. For a 42 years female, and when she has a 3 centimeter tumor and axillary lymph node as well, for these kind of patient, if we could see her upfront, I think first thing we'd like to do is a core biopsy, and like if possible, if it permits us, we'd like to do a IHC for ERPR and HER2/neo. And when we have a triple negative cases, we would prefer for a neoadjuvant chemotherapy, because that is the main thing that we need to go forward for a triple negative breast cancer right now. So I mean, like to go for a neoadjuvant chemotherapy.
So, but I mean, what do you expect?
If you don't have a Well, I think right now the profiling is very important in diagnosing the patient with breast cancer right now, because it determines how you're going to go forward. But doing a surgery upfront is not wrong, but I think neoadjuvant chemotherapy in this case would be a right way to go.
So what are you expecting after neoadjuvant chemotherapy? I mean, why not surgery upfront? What do you expect from it?
Hello?
My question, am I audible there, Dr. Kapendra?
Yes, I can hear you right now, yes.
So my question is, what do you expect after giving neoadjuvant? Why neoadjuvant rather than upfront surgery? So that's my question here.
Well, if you do a neoadjuvant chemotherapy and if you get a good response, that means if you get a T0 response, in that case, the outcome of the patient is much better than having a residual tumor. And if you have a residual tumor, then you may have to opt for, like for example, continue with capecitabine.
Fair enough. So these are the points that I have highlighted here again. Yes, of course, it facilitates breast conservation and can render inoperable tumor operable. So apart from that, some of the points that we as oncologists, we see the treatment responses. identify patient with residual disease for whom we could give some supplemental treatment. Also, there are factors like if we could allow time for genetic testing and time to plan for breast reconstruction. So this was a study that was doing round in 2018, interesting study done by the EBCT-CG group. Well, these are the group from Oxford, and I mean, they are quite stringent about doing studies. We have seen that during this COVID era as well for the recovery trials and all. So it was a long-term outcome for neoadjuvant versus adjuvant chemotherapy in early breast cancer. It was an individual patient data meta-analysis with 4,700 around patients involving 10 trials, nearly 80% patient receiving anthracyclines. Around 2/3 patient with NACT had complete or partial clinical response. 65 versus 49% with NACT versus adjuvant going DCS. Interestingly, the point that struck us in 2018 was this thing. The 15-year local recurrence was 21% for NACT versus 15.9% for adjuvant chemotherapy. So that was 5.5% increase. However, the overall survival, there was no difference. So my question to panelist Dr. Prafulla here, as a surgeon, does this data bother you at all?
Hello. Good evening. Good evening to everybody. Thank you for being present in this great discussion. Now, this 2018 study, now it's an interesting study. As Dr. Sogat has shown to us, interestingly, the patients who have undergone neoadjuvant chemotherapy have more recurrence rate, right? So it has a nearly more increase in 5% recurrence rate. And this can be due to various factors. And this, to some extent, is not a very good meta-analysis. Few things we have to see is the trials are from 83 to 2002. So if you read through this meta-analysis, not all the patient has got taxanes or anthracycline-based chemotherapy. Although 81% is there, but some have gone through or not received. And in this, out of 10 randomized trials, 2 patients who have received neoadjuvant chemotherapy and had a PCR, they haven't undergone any surgery. So this could be a factor of why there is more recurrence in patients who have gone neoadjuvant therapy. And another thing is, definitely this study shows that there is an increase in local recurrence, but overall survival has no difference. And this study also points out the advantage that of neoadjuvant chemotherapy compared to adjuvant chemotherapy in breast conservation rate. So we have to take this trial very cautiously. For my concerning factor is a large amount, 2 big trials, and 2 trials didn't do any surgery after a PCR. So as a surgeon, to some extent, it gets difficult for us to quote trials and plan for breast conservation surgery. And I think if Sogat will think about something else, but still BCS, most other studies do show that neoadjuvant therapy is as good as adjuvant chemotherapy for the overall. It has as low recurrence rate as possible. So Sogat.
Yeah, Professor. In fact, there are many flaws in this meta-analysis. I'm quite aware of that. So some of the flaws that I have pointed out here. So we don't know the exact lymph node status that was before and after the neoadjuvant treatment in these trials. I mean, they were incorporating old trials before the advent of neosystem. That was before the advent of neosystemic treatments. And well, this is one of the points that I thought about. It was there was delayed surgery for those tumors that were not responding to NSCT as well. So this could be one of the points. However, let's take a consensus here, like for a triple negative cancer that's proven on a core biopsy, as a surgeon, are you going to send the patient to your oncologist for neoadjuvant chemo?
Definitely. There is no doubt about it. Right now, this patient which we are talking right now, who has undergone MRM, this patient is actually a very ideal candidate for undergoing neoadjuvant chemotherapy. Like we have discussed before.
So your reason for sending the patient would be to see the prognosis and to decide on supplemental treatment on that, if I muster that?
True, exactly. So if we can get, if patient has a complete response, right, that is prognostically very important comparative to the after adjuvant chemotherapy. In additional, right now for neoadjuvant patient, we do give additional capecitabine right now. So that also is plays a part for these patients. And we do
I'll be coming to that part.
We do have time for genetic germline mutation also if you do neoadjuvant chemotherapy. That is a very important part.
Yeah, that's a good point that you raised. I'll be coming to that as well. So Dr. Kapendra, so I lock things here. So we are sending triple negative patients for neoadjuvant therapy. I mean, that's the practice everywhere nowadays, I think.
Yes.
So that's a common consensus here.
Yes.
Yes, and apart from that, like Dr. Prafula said, I think in this study there are many flaws. One of the main flaws is they have not divided the luminal types, luminal A, B, or triple negative case. They have just taken it as a whole. And the adjuvant chemotherapy for these patients based on this luminal is different. For example, for early breast cancer, if you have a ERPR positive and HER2 negative cases, those cases are not very ideal for adjuvant chemotherapy. So everything has come into this. So that is one of the biggest flaw in these cases. And as for the triple negative cases, I think it has already been proved that neoadjuvant chemotherapy is the best way to go forward for them.
Yeah, fair enough. But I think they do have a subgroup analysis on the forest plot where I think the plot was crossing the unity. Anyway, we are sending those patients for neoadjuvant chemo. So I come down to other question, Dr. Kapendra, for you. So would you like to discuss with the additional surgical treatment if this patient is a germline BRCA positive patient?
Yes, definitely. Because right now, for these triple negative cases, germline mutation of BRCA is very essential. The question that comes into our clinical scenario is, are they affordable or not to do that? Because the cost varies very greatly. And like Dr. Dhar has already said, I said that you can not only just do a BRCA1 and 2, and you can do a plethora of tests. But right now, I think doing a BRCA1 2 is the basic thing that some of our patients can afford. And those people who can afford, we are trying to do that. And another good thing about this is if they are positive, we have the choice of PARP inheritor because that right now is in metastatic cases, we can use that. But few trials are coming up, like Olympia trial, which is talking about giving olaparib in adjuvant setting as well.
Okay, so in your day-to-day clinic, how often do you counsel these? I mean, try to send these patients for genetic counseling, like this kind of young lady with the core biopsy of triple negative for some genetic counseling?
Yes, definitely. Although some of the patients cannot afford, but we do inform them that there is something of these kind of things, and which we try to counsel them for doing it, and the benefits of that. And with the introduction of olaparib PARP inhibitors, it has become more easier for us to convince them that it should be done, and we are trying to do that.
Well, fantastic. Well, suppose in this case, if this lady is found to be BRCA positive germline mutation, so would you go for any risk reducing surgical treatment or some kind of close follow up? So how do you deal with such cases?
For these cases, I think when they have a germline mutation of BRCA, then the first thing is I think we have to do a very big counseling for them. And sometimes those counselings are not enough by ours. We need, like Dhar has already said, we need a genetic counselor for that. We had one genetic counselor, but right now she's not in the country. We usually refer the patients to them. But apart from that, it's not only just doing risk reduction mastectomy. Another thing that is family counseling and other cases like doing risk reduction oophorectomy as well. But these cases are also there. So we have to counsel them about that. And it may not be in the same sitting, but we have to tell them in future she will be needing these two surgeries as well.
Well, fair enough, fair enough. So this was the point, as you said, fantastic. So let's move ahead. So it's to Prafulla here. Prafulla, I think we've seen this data coming from 2017, a retrospective data. So for all those for BRCA positive patient undergoing prophylactic mastectomy, that was compared with the nipple sparing surgery. So I'd like to gain some insights from you about nipple sparing surgery. You see better cosmesis, it's good for the patient, better quality of life. So these are the things. So how often, like, have you ever met certain such kind of patients coming to you and you offering nipple sparing surgery for such patients in a prophylactic setting?
Now, this is a bit difficult for me to answer actually. So in context to BRCA, we have very few people who really undergo BRCA testing in Nepal actually. And having on top of that, having positive BRCA is even fewer. And I think BRCA, the issue is, it's not about just the positivity, it's about the penetrance of the BRCA gene. That also we have taken in mind. Now, if a patient is both BRCA and 1 and 2, they're positive, then you have a 90% chance of lifetime incidence of breast CA, right? Now, if BRCA 1 and 2 is positive, I would definitely advise for prophylactic mastectomy for this patient, especially with strong family history. And talking about the surgery, if you see this study or since the 1970s, where NSCP trial with mastectomy and plus later on with skin sparing or nipple sparing surgeries has been performed, there is no difference between the recurrence from a mastectomy or nipple sparing or skin sparing. Now, but the catch is nipple sparing or skin sparing, the learning curve, it takes a bit for the surgeon, because invariably in these both surgeries, you tend to leave a small amount of breast tissue, and that's where the recurrence comes. Now, with addition of radiation therapy, the recurrence has definitely been low. In our own practice, I haven't done BRCA positive, but we very commonly do nipple sparing as well as skin sparing mastectomy.
But let me get to the point of Prafulla here. As far as I know, I have read, so most of the recurrences, they occur towards the distal part of the terminal lobules. So it's not that the distal part we're taking out, it's just the proximal part that's left. So do we worry about recurrences here, there, in that position? Or how common is it?
Not really. Now, if you're saying like proximal part, like which part you are referring to towards from the nipple proximal or from the base proximal?
From
the nipple. Hello, Sagat.
From the nipple proximal,
exactly.
Hello.
So initially it had said 2 centimeter you need in the nipple area complex. Then it came as 0.5. But now with frozen section, I think we are just leaving around 2 to 3 mm of tissue. And if the frozen section shows that there is no tumor, then we are okay with it.
Okay. So while talking about prophylactic surgeries in such patient, I couldn't restrain myself from talking about nipple sparing for invasive disease as well. I know this is one of the most controversial things. Even in Tata, in our days in Tata, I think they were performing quite, in a minimal amount, they were quite skeptic about it. So for an invasive disease, what's the take on nipple sparing for an invasive disease? It's for you, Prafulla.
It's actually, it doesn't make a difference. Like generally speaking, like I said before, for nipple sparing, initially you need a 2 centimeter. 2 centimeter tissue. Now this is not for the recurrence actually. This is because the nipple necrosis.
Okay.
Right? But now now this is where the MRI comes up to us to some extent to help. And even now with frozen sections, if we think the tumor is very close, like near to the NAC, Then we send a frozen section after nipple NAC under NAC surface, and if there's no tumor, we are okay with it. And we are having excellent results right now with nipple sparing mastectomy, even in invasive disease.
So how frequently are you doing nipples sparing in Harisiddhi?
So in Harisiddhi, maybe Dr. Kapendra and me, we will do around 3 to 4 in a year. Not great amount, but depending on the patient choice, right? If you do a nipple sparing, then you need to do a flap, or you need to put an implant. Now this is very expensive, and patient unfortunately being a low income country, and most of the patient can't afford that extra money, so they end up choosing for mastectomy.
Dr. Kapendra, how would you choose a patient in an invasive disease? How do you choose a patient for nipple sparing surgeries?
Well,
I mean, any sorts of criteria? Yeah, I know. I mean, just let me rephrase this thing. Because sometimes ago, I think the ASCOs, the breast cancer societies, and all the surgeons were there put up a specific sets of criteria. Down the line, over the years, I mean, they have removed some of those. They've said, no, we can do it in everything. We could do it everything. So how did you prefer an optimal requirement for performing a nipple sparing for an invasive disease?
Well, I think when we consider nipple sparing mastectomy in any cases, the first thing we see is, again, we go back to the basic, that is the grade of the tumor and the basic ERPR and HER2/neu of the patient. So we usually try to do patients who have a better outcome, like ERPR positive and HER2 negative cases. Second, from that, we see those TNBC cases who respond very well to chemotherapy. These are the patients whom we opt for a nipple sparing mastectomy. And again, like Dr. Prafula just said, we try to see where the tumor is located at. If the tumor is located very near the central quadrant,
that's absolutely.
We are a little more skeptical of doing a nipple sparing mastectomy, and we'd rather do a skin sparing mastectomy in those cases. And the third thing is really, like we just mentioned, the economy plays a very big part in our cases scenario, because right now we are doing maybe LD flap, or we are doing a triumph flap, or we are doing implant based and LD flap reconstruction in these kind of cases. So these patients are the patients who have done well with neoadjuvant chemotherapy and who have had a very good response. And if they have initially, if you are going to do upfront surgery, in those cases, we try to see if they have ERPR positive HER2 negative cases with low nodal status. And these kind of cases, we encourage for nipple sparing mastectomy.
Okay. In fact, it's quite surprising when I see a group of patients, because they are more comfortable with mastectomies rather than any BCS or this kind of surgeries. A patient, I mean, they are still, I think, they worship Halstead here.
True. That's true. That's how people understand,
isn't it? So let's continue with this.
A lot of people think that just taking out the breast solves all the problems. And and a lot of our, let's say, the patients who have been treated, let's say 5 or 10 years ago, who are doing very well, they are the patients in those days we were just doing mastectomy, and they get the example from them also. So those are the reasons why people opt for more of a mastectomy. And there was an interesting study in US also among medical professionals who are asked if they had to do a mastectomy or a breast conserving surgery. Surprisingly, the medical fraternity also opted for mastectomy rather than breast conserving surgery. So
interesting.
Yes.
That's interesting. That's interesting, because like in our practice in India, in Tata, when we used to be there in MDT, we used to have around, let's say, 50 patients a week in the MDT post-surgery. But the beauty about the MDT is we used to have 90% of the cases undergoing BCS rather than mastectomies somehow.
Yes.
So let's continue with the case. Yeah, Dr. Kapendra.
Yes. Well, even in our case scenario, like in Nepal Cancer Hospital, Harisiddhi, we do around 200 cases per year, and nearly around 60% of our cases we are right now doing breast conserving surgery.
Okay.
So the breast conserving surgery trend is coming up, and we are doing a better amount of cases in that. So I think it's also catching up in Nepal.
So any audit the profile of how many BCS has been done in Harisiddhi?
We have around 50 to 60% patient undergoing breast conservation right now. Now, this to some extent has decreased because of the COVID situation. Now, as we have the lockdown, more patients have come in more advanced disease state. So I think it might has come down to around 35 to 40% now.
That's extremely sad.
Yeah,
without wasting time, I'll continue with the case here. So the patient was treated with dose-dense AC for cycle, followed by weekly paclitaxel for 12 cycle. So this was followed by adjuvant RT. She completed a treatment about 4 weeks back. So actually, this was a question that was meant for Dr. Baral, but since he's not here, Praful, I'd like to carry on with you. So do you want to offer any supplemental chemotherapy in adjuvant setting? Just remember, she was operated upfront, 3 centimeter tumor, triple negative, grade 3, a young lady. So do you want to offer any supplemental chemotherapy in adjuvant setting here?
I see where you're going from this study. So this is something that is like even in NCCN 2021, this has been discussed with BRCA positive, and a new guideline has come out according to these type of features. The treatment of triple negative breast cancer with BRCA or without BRCA, but to this scenario at present, my hospital, my team, we wouldn't think of using adjuvant any additional adjuvant chemotherapy. But this, I see this study you are showing, right? And this is a very interesting. This is a Chinese study that's recently been published. But it has shown that capacitabine in low dose does have a good, better survival, disease-free survival compared to people who are in the observational group. But I was going through literature yesterday, and this is the only trial that has shown that low dose capacitabine is better. But other trials till now, most of them refute that additional capacitabine has any benefit at all. So this is the
exactly.
I hope we can in our context also, it's very possible to study, and it's a very simple study. I hope medical oncologists take up this challenge and prove something new.
Yeah, before I move on to medical oncology, I'll just read out the nitties and gritties of this trial. So it was a low dose maintenance capecitabine in a very low dose that was compared with observation. So the median age was exactly like our patient, 45 years in the experimental arm and 48 in the observation. So the interquartile range quite falls within our patient group, young patients. So capecitabine was given at a dose of 650 mg per meter square twice daily for 1 year. So after a median follow-up of 61 months, the interquartile range being 44 to 82 months. So there was a difference, and which was quite significant in disease-free survival in the capecitabine group compared to the observation group. But here is a peak here.
Dr. Paudel, it's more than half an hour now. So it's everybody.
So I'll.
You should,
yes, sure, sir.
I think you should conclude the.
Okay, sir. So this will be my second last slide. Yeah.
We'll just answer yes or no, nothing else.
So this, but yes, of course, there are some issues here. The benefit in DFS rather than OS. So are we taking such patients? Are we prescribing such patients chemo with certain amounts of side effects for the benefit in DFS rather than OS? So that's one question. But there was an interesting thing when I looked at the Kaplan-Meier curve. If you look at this Kaplan-Meier curve closely, most probably after 5 years, there are some group of patients who are benefiting with capecitabine. I think this needs a longer follow-up here. It's true, Prafulla. This may be my last question here. So, Dr. Prafulla, for further supplemental treatment, if the patient is found to have BRCA1 or 2 pathogenic or likely pathogenic variant, would you like to consider for further supplemental treatment in an adjuvant setting here? So, actually, this is for medical oncologists here.
I think olaparib has been recommended for BRCA1 and 2 right now for duration of 1 year.
Yeah.
I think we as right now can't afford it, but this seems a good option for people who can to afford it.
Okay. So any flaws that you feel about this trial here?
They actually, I was going through this trial directly. But I see it's like still an early trial. There hasn't been enough time for it to see. Just I think it's 2.5 years follow up. You can take it to 5 years, and then it will make more sense. I think, sir. I think this is a early midterm follow up, right? This is.
Yeah. This is an interim analysis here.
Yeah, interim analysis. That's right. But unfortunately, okay, definitely. Sorry.
So exactly, it's an interim analysis. Well, the question is whether it's too early to accept the result. Yes, we have seen many situations where the DFS hasn't translated into OS. And of course, do we need to wait for the OS benefit? So, of course, we now have capecitabine in those with residual disease after neoadjuvant, which has now become the standard in many of the institutions. So it was not given in the placebo arm. And of course, there is a cost of medications involved. Final question, I'll end with this. Dr. Hari, please give me time. So the lady in question desires for a delayed reconstruction after her RT. So Prafulla, my question is, how do you proceed ahead with her in that case?
Generally, after RT, delayed reconstruction is 1 year after RT. I mean, it's a very good option. We counsel all the patients for this at presently undergoing mastectomy, and I hope that people do come up and they undergo for a reconstruction process. I won't take much time, but we prefer autologous type of reconstruction.
So it's autologous.
Yeah, we prefer autologous.
Okay. So last thing I wanted to discuss with Dr. Aparna as well, but I don't think we have any time. So with this, I'd like to conclude and hand over to Dr. Hari. Thank you.
Thank you, Dr. Paudel, for a very nice panel discussion on triple negative breast cancer, more with a clinical perspective, what to do and in our situation. Now, I am handing over the mic to Dr. Madan Piya sir for the question answer session.
Thank you very much for very good discussions. Regarding capecitabine, I didn't have much experience, but in triple negative, I didn't have a good results because I treated in 3 or 4 patients and most of them recurred after 6 months in triple negative with oral capecitabine. Anyway, so thank you very much for all the members and participants in the interesting this debate. Now, I don't know, it's 7 o'clock, so almost 7 o'clock. So I don't know whether there is any time for question and answers. It depends on.
I have a small comments, sir.
Yeah.
Because I had one patient actually, I would like to comment on the presentation of Dr. Sudip. Whenever you see the long mass in non-smoker, especially in young age, even after doing baseline marker for non-small cell lung cancer, which is not contributory, I think you have to think, especially in case of poorly differentiated carcinoma, you have to think about pulmonary not carcinoma also. I requested for solid panel fusion gene, 50 gene panel, and the result was not M1 gene fusion, positive for not M1 gene. For that, you have targeted therapy also. So NCC guideline also pointed out, especially in poorly differentiated non-small cell lung cancers, especially in young age and non-smoker, you have to think about pulmonary not carcinoma also. That's what I wanted to cover.
Any comment from Dr. Aparna?
No, it was just a very interesting, fun session. So thank you so much for having me here today. And it was actually lovely getting to put faces to a lot of people who have had the pleasure and the honor of interacting with over WhatsApp and over calls. So it's wonderful meeting you, e-meeting everyone. So thank you so much for having me. Thanks, Vikas, for organizing this.
Thank you, Dr. Aparna.
I thought there was one question, but no, I can't see that question. Can the co-diagnostic people can see it?
So I answered the questions. I've closed it.
Well, having said that, so I'll hand over this mic or mic to Dr. Dinesh Doval. Dr. Doval for his comments and take-home message.
Dr. Piya, thank you so much for giving me this opportunity to say a few words before we close off. It was an immensely brainstorming session and led to a lot of broadening of the horizons when it comes to precision medicine and molecular profiling. So, in the present day scenario, comprehensive genomic profiling and GCP is indeed the beginning of a new era, and I think once we are thinking of precision medicine and giving the right drug to the right patient at the right time, I think molecular diagnostics is one of the very, very important thing for this in this particular scenario. So we are moving from multiple omic technologies, and I think the platforms like profile genomic, transcriptomic, proteomic aberrations of cancer, and will guide in the further treatment of decision in the precision tumor to respond to the best available therapeutics. So I think we are not only looking forward to this profiling at a later point of time in tumor progression, but I think the earlier we do it, if you know that this tumor in this particular patient has got such aberrations which can be targeted, I think we can treat the patient better. And I think it can even be economically more viable that we are not able to, we don't waste unnecessary time and money in investigating and what the precision treatment can really help us. So I am very delighted to be part of this conference, and interactions have been very, very good. And I hope Corona spares us the time and we have some face-to-face meetings so that we can better interact with each other. And thank you all. Thank you, Dr. Piya, for the kind invitation. Thank you so much.
Before I leave or hand over to the core, I just want to ask one question. So we talk about NGS and all kinds of things, Well, what is the cost of doing single gene or multiple gene studies?
I think core can answer it better. Dr. Dhar.
I'm not going to comment on the cost because I'm also as clueless as you are. But yes, when we increase the number of genes, it does reduce the cost significantly. So we do prefer single gene panels like a BRCA1, BRCA2. If I don't know what the cost is, but I also know that my multi-gene panel is somewhere around the same price range, which is around 98 genes. So more genes in one run, it's just easier, quicker for us. So the cost does come down. Exact pricing, there is Mr. Vikas Watson, he's the right person to tell you that. But single gene is much more expensive. There's more run, there's a longer process. So we definitely recommend multi-gene, at least a 5-7 gene panel versus a single gene.
I think what can be done is that we can have a, you can make panels like, for lung, you can have, a 30 gene or 50 gene panel, which
we
is
have
nothing
those.
much.
We have those.
Yeah,
it's already in practice.
Yeah, I think, and more we use it, the cost is definitely going to come down the more we ask for it. Absolutely. Because I remember if you're sending to a foundation one, you are going to pay around 3 lakh rupees. If you do it in a home brew, it might be 50,000 or 50-60,000. So I think we should come out with a policy where, because what we are doing these tests, they are meant for use to the patient, and unless until we are utilizing them for the patient, I think it's no use developing these tests. So I think they should be affordable, reachable to the patient, and I think that's what Dr. Piya really meant.
No, but with Mr. the demand, Vikas, we have seen it.
Do you have any rate for us?
Yeah, there is.
No, I think
earlier the price which was
20,000
for BRCA or for multi-gene. No,
BRCA also is a cost because BRCA I think in Nepal it's come down to 30,000 Nepali. So that comes to about 18,000 IC.
Yeah.
Even
about
lower than
yen-
that. Even lower than that. It's costing. I can say 16,500 IC to the patient now these days.
Mhm. And what about NGS? Because in every Indian this these conferences, they talk about NGS, don't talk about anything except NGS. So what is the cost of NGS?
So the cost he gave you is NGS. NGS is the technique that we're using for calling out these mutations in these genes.
Mhm.
So the cost he gave you of 16,000 or whatever for BRCA testing, that is done on NGS. That's the platform we're using. So NGS it becomes a very broad-based thing. Instead of saying BRCA1, BRCA2, PALB2, CHEK2, instead of calling out mutations, it just becomes so much more easier to say, oh, we do an NGS. So like how we used to do PCR of fish once upon a time, we still do it, but now we just say next generation sequencing, NGS. So it's just become a much more broadband term.
Okay, now I'll hand over to Core.
Yeah. So thank you all the eminent faculty members to spare time from their busy schedule. It was really a fantastic educational evening for all of us, including all the doctors who joined from Nepal. I would look forward to have a great professional relationship with all of you, and very soon we'll come with all our range of products based on NGS with the best pricing. Thank you again. Have a wonderful evening. Bye.
Okay.
Thank you, Dr. Piya, and wish you all the best.
Okay, thank you. Hoping to see you soon.
Sure. Okay.
All right. Thank
Okay,
you.
bye bye. Take care.
Bye. Good night.
Okay.
Thank you.
How is Corona situation in Delhi, by the way?
There's no Corona in Delhi now.
What
Corona
about
is-
this third variant, Delta variant?
Yeah, Indians are now welcoming the third wave. They are, yeah.
But there's nothing like the third wave right now. We are quite comfortable here, and there is no. I have seen the worst of the times when 2 weeks we could not sleep because so many calls used to be there regarding for admission of patient, this relation or somebody like that. So now that all that is gone, and there is no patient now where we have the corona with reserved wards.
No, because you see, I'm asking you, Dr. Doval, because so many people, patients, still want to go to Delhi, and not I'm not talking about you, but the doctors are saying, "Ale, abhi mat aao, aane ka time nahi hai."
No. I think now the flow has already started. Earlier about a month ago, there were 3-4 months ago, there were no patients for past 6 months or so. But now the people are coming on their own. They've already started coming.
Okay, thank you.
So there's no. I think if they follow the COVID culture, I think that's what we are all masking and keeping distance and all that. Yeah, that's all.
Okay, anyway, thank you very much again.
Thank you, sir. Thank you so much.
Bye bye. Hariji, thank you. है
Thank you,
Dr.
sir.
Hari, thank you.
मलाई सम्झिनु भएकोमा धेरै धन्यवाद.
Thank you.
Okay, sir. Bye, sir.